So let's start with the basics. What is an orthotics? Orthotics meaning straight, upright, or correct. And it's a static or a dynamic device and is preferable to a splint, which is a static device. Doesn't help in correcting, it's just helping maintaining the deformity, maintaining the correction. So that's why we need orthotics, more so in foot and ankle conditions. And it works by 3 points principles, where a single force is placed at the area of the deformity or the angulation. And then you have, of course, 2 additional counters acting in the opposite directions. Functions of orthotics, of course, we know the fact, it helps in preventing the deformity, helps in the functions of a weak limb, maintains the alignment, proper alignment of the various joints in the foot and ankle. Of course, protects an injured joint, allows for maximal functional independence, and of course facilitates motion. So we need stability along with motion, and that's what it is. When we are prescribing orthotics, we need to look into the cost as well, more so especially depending on the socio-economic condition of the patient. But at the same time, we need to make sure it is energy efficient, cosmetically acceptable, and sometimes a patient may need to wear it for a prolonged period of time. So what is the type of material we are going to use? Is it dynamic or is it static? And patient be able to use it in a routine life so the compliance improves. Because we know the fact, even if the best of the orthotics in the best part of the world, you would say, the compliance ratio and the satisfaction ratio is only 70 to 80%. So not every orthotic, irrespective customized, prefabricated or whatever, is going to solve all the problems. And it helps in changing the foot and the leg alignment as well. Foot orthotics, it's a semi-rigid. So what is it? It's a semi-rigid or a rigid insert worn inside a shoe that corrects the foot alignment and improves the function, thereby relieving the pain. Slightly busy slide, but you can use a foot orthotics within the shoe or outside the shoe. If you're looking within the shoe, there are different types of materials involved. You have a soft inserts, which helps in reducing the area of high pressures or high forces, and thereby protecting the painful or the sensitive areas of the feet. You have metatarsal pads. So every time I remember when I was doing my MS, everything in the forefoot metatarsal just gave a metatarsal bar. And I presume a lot of people still do that. So what you do is in a metatarsal pad, your pad is just posterior to the metatarsal heads. It takes the pressure off the metatarsal head, leading to the pressure onto the metatarsal shafts. Helps in allowing a better push off in a weak or inflexible feet. And then of course you have patients with heel pain or pain in the hind foot area, you give a cushion heel, which basically absorbs the forces at the heel and relieves the strain on the plantar fascia. So these are the kind of things you get off the shelf. Metatarsal pads, every patient of neuroma, every patient of synovitis of the MTP joint, you just give them a neuroma pad or metatarsal pad. And these are the off-the-shelf heel cushions. You'll get a heel spur pad and everything. So in a foot and ankle, there are 2 types of orthotics which we use. You have a prefabricated and you have a custom. Of course, prefabricated, it's lower the cost. Company is manufacturing in bulk, so the cost is low. You can stock in your clinic or it is available down the road in the pharmacy. And it's easily available. But the key thing is, if your patient is in the normal range, fine, this will help. But if they're slightly off, then you will not be able to use these prefabricated orthotics. Customize, of course, helps in patients who are out of the average. The patient is quite happy if they want it. But of course, it adds to the cost of it. And over a period of time, do we know is it better or not? We don't know. So prefabricated, what are the orthotics we're looking at? We have in-shoe pads. So we have metatarsal pads, you have a callus cushions, medial arch supports, heel pads, cushions. You get all this off the shelf. Insoles, I don't know if in Jabalpur, but in Mumbai we have like 3-4 companies who most of them are insoles are kept with the physiotherapy. So almost invariably alternate physiotherapy, people keeping the insoles with them, and every patient who goes with any type of foot and ankle problem insoles are given, and that's become that common. So every patient gets an insole, prefabricated. 1,000 rupees, yeah, wear it, it'll be solving all your problems of your foot and ankle. Countered insoles again relieve the pressure of the foot, dissipation of the impact. So insoles are not bad, but does it really help? We don't know. If you look at custom orthotics, the key thing which you need to realize is it going to be a corrective orthotics or is it an accommodative orthotic? And the difference is quite a lot, because if you have a rigid deformity, then you're looking at an accommodative footwear. And invariably for a rigid deformity, you would start using a customized insoles, customized orthotics, I would say. Because there you would need to make sure that the pressure distribution is done in a proper manner, and also at the same time, if there are any bony lumps or deformity, those are also taken care of. Also, you need to look at the function as well, where you're looking at stabilizing the joints and preventing untoward movements or instability which is there in the joint. That's been taken care of as well. And of course, you have the AFOs, which are mainly used for, as Dr. Rana said, if you have a Charcot neuropathy, or if you have a foot drop, or if you have a severe adult acquired flat foot and patient does not want to get anything done, then you would need an AFO to correct it. What are the types of materials or types of orthotics which you're looking at? You can have a soft, semi-rigid and rigid. And soft is used to dissipate the plantar pressures and accommodate the deformity. Semi-rigid usually will have a slightly firmer material, and rigid of course will have a thicker material. Now what are the materials? I know we don't do anything, but it is better and it is important for us to understand what type of material. Because if you talk to an orthotist and will say, he needs so and so, and the orthotist may say, okay, I will make so and so. You need to know, is he talking the right language which you have been looking for, or which you understand as well. So key thing which I have marked red. So soft, usually people do is a plastozode or a EVA, ethylene vinyl acetate. These are softer material, takes a good care of the pressure points, and usually used in diabetic foot, rheumatoid foot and KVS foot. So they help in pressure distribution. Semi-rigid, you will have a 3/8 inch of a polypropylene. That's a very commonly used. Again, they're not too rigid, slightly rigid. So if you have a very mild flat foot going through it, or patients with sports injuries, you have a patellofemoral syndrome, subcalcium, mild to moderate pronation, this is the kind of, so off the shelf, if you get your insoles, this is what you probably may have as well. Slightly firm, but rigid is where you start getting severe deformities, but they are flexible and you want to correct them. So you have a flexible collapsing flat foot, and if you want to correct that, you are looking at a 1/4 inch polypropylene. So these are the kind, or if you have a coalition and ankle instability, that's the kind of material you will be asking your orthotist to use in the orthotics. So let's look at the different types of pathologies. First, MTP joint pathology. So you can have a degenerative, so hallux rigidus, turf toes and injuries to the access points. So what are you looking at? So assuming you're looking at hallux rigidus, where you want to prevent the movement of the MTP joint. So you could ask your orthotist to either give you a customized or a carbon fiber plate, a carbon plate sole. Now that's quite expensive, not available, but if you can get hold of that, you can use a carbon fiber plate that will prevent the MTP joint movement and the patient will be happy. Or the other case is like in A, you can get something done for the great toe that will prevent the movement of the MTP joint, patient will be happy. You could ask for the other range of movement. So like in B, where you give a metatarsal pad under the second, third, fourth, fifth metatarsal, and that also will be there. Or you could do an offload the plantar pressures and loading of the joint. So depending on what you're aiming to do biomechanically, you need to understand what you will tell your orthot. You just cannot send the patient to the orthot and just sort him out. That's not the way it would work. You want to know if there is a area of pressure. So area of pressure. So let's assume. So coming to this, central metatarsalgia, what you're looking at. So if you have a MTP synovitis or a loss of plantar flat or an interdigital neuroma, what would you want to do? So your strategy is block the movement of the MTP joints, okay, or offload the metatarsal heads. So this is what you're looking at. So you see in here, you would give a rocker bottom just proximal to the metatarsal head. So the metatarsal heads then get offloaded, the synovitis settles down and the pain settles down. You may also want to give a figure C here. So that's the one. Or you can do a direct offloading as well. So if there's a pain there, here. If there's a pain or tenderness present only on a certain metatarsal or a second or a third, you can ask the cutout in your metatarsal pad. So that area is not under pressure and the patient will get relief of pain. Heel pain already being covered early morning. You know the fact that you need to offload the central area, the plantar pressure area, and also you need to support the medial longitudinal arch if there is a drop or a flat foot. So that's what the deformity you need to correct it. Heel lifts are quite good, especially if patients who have TA tightness or a gastroc tightness, it just offloads that your gastrosoleus complex and helps in relieving the symptoms as well. And at the same time gives you a nice cushion as well. Now coming to flat foot. Key thing in flat foot is the UCBL, which is University of California insert, which is a semi-rigid plastic molded insert to correct the flexible flat foot. You have a scaphoid pad and you have a Thomas heel. You understand that. So just sending the patient to get the scaphoid pad for the arch is not good enough. You need to make sure you correct the heel valgus as well. And I'll come to that in the forefoot, what you need to do. So you're not only just doing this, you're also giving a heel wedge and a heel correction to correct the valgus. So this is what I was talking about. So your forefoot posting, if the forefoot is in varus, then you would need a medial wedge in your forefoot as well to correct your hindfoot as well. And vice versa for forefoot valgus. So you understand, in a flat foot you will get a forefoot varus, so forefoot supination, and in cavus you will get the other way around. And at the same time, as I was saying, so a post is also required for the hindfoots. This is where it is. So a varus post, which is a medial wedge post, it limits or controls the eversion of the calcaneus and internal rotation of the tibia after heel strike. So it reduces the calcaneum eversion. This is what happens when you are in a flat foot. The calcaneum goes into eversion. So you need a medial wedge, and vice versa for a cavus foot. So in a flat foot, yes, you could give a foot orthotics or you could give an AFO. Both has its own advantage and disadvantage. Understand that and accordingly prescribe to your patients. The only problem is this is more patient compliant. This you can have a much better control of the foot but less compliance to the patient. So depending on what degree of deformities you have, please use it accordingly. And this is what it is. So yes, you could use a custom rigid prosthetics or AFO, or you could use a hinged foot orthotics, but it all depends on what you are trying to achieve in your patient. Like this kind of stuff, and AFO, if I start giving to every patient of mine, yes, you will get a good correction of deformity, but the patient will probably go next door. Okay, so understand what your foot orthotics or AFO is trying to do or trying to achieve. So example, this patient, if you are planning to, if it's a severe deformity, patient is quite painful, you advise surgery, but patient is quite adamant they don't want surgery, then the compliance for this may significantly increase. Cavus foot, again, it is, as I said, if you were to choose between a normal foot, flat, or between a flat foot and a cavus foot, I would choose a flat foot because cavus foot has more issues in foot and ankle than a flat foot. They have high plantar pressure, so they have a high incidence of heel pain, lateral side pain, ankle sprains, insertional tendinopathy, blah, blah, blah. So what you want to do is you, by cushioning and by giving a heel raise, you're reducing the plantar pressure. So you're using a polypropylene shell one day that is inserted with a nice material, a softer material on the top, which takes the whole pressures off, and also the heel pain you're reducing by a plantar fascia groove or by accommodation. I think that's enough for the end of the day. I wouldn't bore you much. Thank you.